So here we are once again continuing our project looking at anatomy with respect to movement as the central point of our network of meaning or our semantic network. So now we're looking at movements of the finger or movements of the fingers, not necessarily the finger, but the fingers. For our objectives, we're going to have a specific discussion of what finger motions are, their standard planes and axes in the anatomical position, general discussion of the muscles that move the fingers, very general discussion of the nerves that supply the muscles that move the fingers, and general discussion of the vascular supply, so the neurovascular bundle, generally speaking. Then a general discussion of the areas to assess and treat should issues with finger motion be suspected or reported by the patient, or suspected by the practitioner and then reported by the patient. So as far as planes and axes, we do our quick review of planes and axes. The sagittal plane is 50% cut of the body left to right. Horizontal or transverse plane is 50% cut of the body top to bottom. The frontal or coronal plane is 50% cut of the body back to front. The axes are perpendicular to the planes themselves. So the sagittal plane has a horizontal or transverse axis. The horizontal or transverse plane has a vertical axis, and the frontal plane has an AP or PA axis, so anterior to posterior, posterior to anterior, whichever term you prefer. With respect to motion of the fingers, so I won't necessarily be able to do this in the anatomical position just because of the camera setup, but if this was beside my body and I was upside down, then flexion and extension of the fingers is in the sagittal plane, right? So it's rotation towards the front of the body or towards the back of the body along a horizontal or transverse axis. So that is your flexion and extension. Your abduction, your abduction, and your adduction are with respect to a midline in the hand itself, right? So not necessarily with respect to the midline of the body, but in the anatomical position, this would be in the frontal or coronal plane about a theoretical or hypothetical rather AP or PA axis. That's not absolutely how it works based on how the joints are built between the carpals and the metacarpals and the phalanges, but that is your general plane and axis. So this is frontal or coronal plane along an AP or PA axis. Again, that's not necessarily how it works, but that's how you would describe it in the anatomical position. Now, if I turn the hand this way, now this AB and adduction of the fingers are technically in the sagittal plane with respect to the rest of the body. So you can have those weird discussions, but the hand, at least with AB and adduction, is with respect to a midline of the hand. Flexion and extension of the fingers, again, with respect to the hand itself, but in the anatomical position, you'd say it was in the sagittal plane. Now, there is no motion technically of these things, or very little in the transverse plane. You can generate some rotation of a finger, of an individual finger. So in the anatomical position, you could say that that was in the horizontal or transverse plane. That's semantics. So technically you have motion in all of the planes, but sort of you do, sort of you don't. The hand doesn't absolutely work that way with clean planes and axes unless you're in the anatomical position. So you would refer to it with respect to the anatomical position or with respect to the hand itself. As far as muscles, right? So with the palms up, right, or with the palm up, movement towards the front or towards the palm or the palmar surface would be considered flexion of the fingers. Movement towards the dorsum of the hand or the dorsal surface or the backside would be considered extension of the fingers, right? So flexion of the fingers, extension of the fingers. So any muscle that is going to generate flexion or extension of the fingers, including the thumb. And with respect to planes and axes, I didn't necessarily talk about the thumb being multiplanar and multi-axial, just because it's essentially a saddle joint. It's very similar to a ball and socket joint. It can move in all planes and all axes, and you have muscles that will AB and adduct it and muscles that will flex and extend it. So anything that does this, extensor is the start. Anything that does this, flexor is the start. Now we get into a slightly different situation with this movement. So you have abductor, pollicis, longus, and brevis. So abductor, pollicis, longus would be in the forearm itself, and then brevis is essentially in the hand, but it will pull the thumb away from the midline of the hand. As far as the muscles that will pull the fingers apart, right? So these digits, these 4 digits, that is the dorsal interossei and then the palmar interossei pull it together. So the interosseous muscles, or the muscles between the bones on this side of the hand, close it. On the back side of the hand, open it. Then you're going to have flexor digitorum longus, flexor digitorum brevis. I believe you're going to have extensor digitorum. So extensor digitorum will do this. Then you're going to have extensor digitorum indicis, just for the index finger. You have extensor digitorum or extensor digiti minimi for the pinky finger itself. So indicis and minimi do this, right? So depending on who you are, you may like this symbol, you may not like it, you may, right? So different cultures will see this differently, but this is possible because you have a muscle that will extend the index finger and a muscle that will extend the index finger, or sorry, the pinky finger. So you can do that, or you can do that. As I said, palmar interossei pull the fingers together, or adduct the fingers. The dorsal interossei adduct the fingers. And then you have a general discussion about extensors, right? Extensors of the fingers, including the thumb, flexors of the fingers, including the thumb, and then you have abductor, pollicis, longus, and brevis to do that. Right? So those are your muscles, generally speaking. You're going to notice, more than anything else, either restriction of the fingers, which is not as likely as you might think. But really what you're going to notice is, when examining the forearm, you'll often notice high tone in the muscles in the forearm flexor compartment or in the forearm extensor compartment. If there is something with respect to the fingers themselves, then you may also notice something with the carpals and the hand itself. So you can look at all of these levels, but as far as the muscles themselves, you're not necessarily going to notice it in the hand. You're going to notice it in differentiation in tone in the flexor and extensor compartments. Now, the neurovascular bundle, very, very broadly speaking, without naming which muscle, which nerve, which artery, which vein, what you're looking at is essentially the forearm flexor compartment for some, right, and the extensor compartment for others. You're going to break down into the median nerve, the radial nerve, the ulnar nerve, then the anterior and posterior interosseous nerves. And that's going to be the control of the hand. So because there's so many nerves or branches of varying nerves, you're not going to trace each nerve necessarily. You're going to look at the compartments, right? As far as the radial artery, the ulnar artery, the anterior interosseous artery, the posterior interosseous artery, the recurrent radial artery, I believe, you're not going to pick these apart. You're going to look at the compartments, but you have all of those named so that you can be aware of them with respect to specific muscles and specific processes. However, in actuality, when you're working from the outside, when you're working as an osteopathic manual practitioner, it's forearm flexor compartment, forearm extensor compartment, how the radius and the ulna relate to one another, or move in relation to one another, both at the proximal and distal radioulnar joints. And then it's how the carpals move, how the thumb moves, how the fingers move in relation to the metacarpals. All right. So areas, I pushed too many buttons. Areas of consideration for assessment and treatment. So because of the brachial plexus being the primary point of control here, you're going to be looking at the cervical column. You're going to ensure that the cervical column is moving as it should. You're going to ensure that the clavicle and the axilla, right? So the clavicle should be moving in its planes, its axes. It should be moving away from the thorax and towards the thorax relatively freely. It should be moving up and down relatively freely. You're looking at the neurovascular bundle there. You're also, when you're looking at the axilla, you're looking at the pectoral musculature. You are looking at the rotator cuff, generally speaking, to ensure that the axilla has some space. You're going to look at the anterior and posterior soft tissues of the arm, because you're going to have the nerves as they descend. The radial nerve goes down the back of the arm primarily, and then through most of the extensor compartment. But you've got it coming down the posterior soft tissue. So you got to consider the tricep, you have to consider the bicep. So you have to go to both sides with respect to the hand. Then you're going to look at the anterior and posterior soft tissues of the forearm. So both anterior and soft tissue and posterior compartments, although it doesn't say it there, on account of the fact that you're tracing the general neurovascular bundle, not necessarily the specific neurovascular bundle or the specific nerve or the specific artery. You just look at the compartments and you'll identify what you need. What you're going to then look at is the carpals, right? So you basically squeeze you put them in between your hands, you squeeze them, they should slide up and down relatively freely. You're going to then more or less look at the fingers themselves. You can, under the right circumstances, hold the carpals still and slide the metacarpals on them, right? So you hold, and I don't have enough hands, but I would hold here, and with the other hand, I would move against the still carpal. So I'd move the metacarpal against the still carpal. You can check that. You can check the finger motion. As far as contraindications and red flags, known or suspected fractures or tears in any of those areas, right? So from the neck to the clavicle to the axilla, to the humerus, to the radius, to the ulna, to the carpals, metacarpals, phalanges, known fractures, known tears, you don't treat them because you can cause more damage to them. Suspected fractures or suspected tears, you refer out for differential diagnosis by a professional who can see things that you can't, which generally speaking would be a physician who can order imagery, appropriate imagery to the situation at hand. So generally speaking, anywhere through that line, known fractures and tears you don't treat. You can treat the patient, but you don't treat in the location or general region of the known fracture or tear. A suspected fracture or tear, refer out.